Hello everyone, happy Friday and welcome to lecture 35 of BMS 300, right? So before we get into parts 2 of the respiratory system, I have an announcement to make about the RPA activities, right? So I had a meeting with Dr. Folkestad, who's in charge of the RPA activities, and I was asking him how can students help improve their practice routine, right? And I told him what I was advising you guys, right? You take 2 RPAs today, 2 the next day, maybe. There's only 5 RPAs at this point because RPA 6 is blood and immunity. It's a mistake, it shouldn't be open. So there are 5 RPAs, if you do even 1 per day, right? And then you start today, by Tuesday you're back to RPA 1, and you keep cycling through those RPAs over and over again, you will be practicing as you should, and you will be in the highest category of practice, right? So that's level 4. And when we looked at the performance in exam 1 and 2, we found that those who were practicing the RPAs in level 4, where they do the RPA activities and then they come back to the first ones and then cycle back to their average was, I believe, in at least 11% higher, right, than those who did not do the RPAs at all, right? So among those who did not do the RPAs, I believe the highest was like 80%, whereas among those who did the RPAs, starting from 1 and then cycling back, they scored between, the highest was like 106 and the least was 0, right? So what I want to highlight with that is it doesn't matter if you only do the RPAs as you're supposed to, you still don't show up and take the exam, you're not going to do well, right? The RPAs are only a tool to help you improve your percentage. So when you compare those who did the RPAs best versus those who didn't do any RPAs, the average was 11%. So that's over a grade point difference. And that being said, I found that around 200 students in the class, they are not practicing the RPAs as they should. So my hope and goal is by making this announcement that you start doing 1 RPA per day, and that you will all end up in the level 4 where you're practicing the RPAs as you should be practicing it. And as I said, RPAs are only an additional tool, so if you haven't been doing this, please work on the key questions, write out the answers. I'm happy to look at your answers before or after class. As you can see, I just walk on making small talk, and I wish I could use that time more effectively, right? So if you bring me your answers to the key questions, I can quickly look at it and offer some feedback as well. Are there any questions for me? Oh yes.
As far as the RPAs go, should we be taking notes on them, or just?
That would be fantastic. Taking notes on the RPAs. And my hope is that when you take an RPA activity for the second time, if you've seen a similar question before, you should be getting that right. You really want your performance to increase from one RPA to the other. And you have sufficient questions so that you can take it multiple times. And because you could take the RPAs and just close your eyes and keep clicking one to the other, and you get nothing out of it. Right? You just get your participation points, and that's totally defeating the purpose. So every time you take an RPA, pay attention to the explanation. If the explanation isn't clear, talk to me. I wrote those explanations, all right? So make sure that you take notes during the RPAs as well, and that will help you to improve your performance. And also, another thing about the key questions, if you haven't picked up your exams, I would highly encourage you to pick up your exams and compare the exam questions with the key questions, right? And it will really show you how focusing on the key questions will pay off. I'm not asking you anything for which I'm not preparing you for, right? If you find any question on the exam which you feel automatically prepared for this question, come and talk to me, right? Because my goal as a teacher is to make sure that your performance reflects my performance in the class as well, all right? So with that, let's get into part 2 of the respiratory system. So here's an overview of what I hope to discuss, right? We are going to talk about the structure of the alveoli, this will be in the context of the components of the respiratory system. So we started at the nasal cavity, we worked all the way down the trachea, we saw how the bronchi were branching, and finally we ended in the alveoli, and I want to focus on the structure of the alveoli. And from there we'll see how the alveoli structure permits the gas exchange across the blood-air barrier. And then we'll move on to the organs which comes to our first comes to our mind when we think about the respiratory system. We'll talk about the structure of the lungs and how the left and the right lung have a few differences between them. And then we'll move on to talk about what are the various steps involving external respiration. I told you external respiration is where you have the gas from the external environment entering into the interstitial fluid and in the bloodstream, and we'll see what are the various steps involved in that. And when you think about factors which influence the inspiration, air entering your lungs, and also expiration, which is air exiting your lungs, we will see that it can mainly be explained by the pressure-volume relationship, which is Boyle's law, right? And this will be the first law we consider. There will be 3 other laws, 4 laws in total, and we'll get to Dalton's law of partial pressure when we come back on Monday, right? And I'll tell you, once we go through all these laws, how you can make sense of these laws' names and what they are referring to, because the name would mean nothing to you unless you have a way of remembering what order they should come in and how they fit into the various steps involved in respiration. So let's start with the structure of the alveoli. So we see that the respiratory bronchiole is shown here, and the respiratory bronchiole is reached by the trachea branching into 2 bronchi, that branches into lobar bronchi, that will branch into segmental bronchi, and finally this respiratory bronchiole will give rise to what is known as the alveolar duct, shown right here. And this alveolar duct is going to open into the alveolar sac. An alveolar sac is made up of multiple alveoli which are connected one to another. And notice that these alveoli have these holes in them, or openings, through which they are connected to one another so that the pressure can be maintained across the alveolar sac. When you look at the outer surface of the alveoli, notice that there are a lot of blood vessels shown here, right? And there are also these elastic fibers shown in brown. And the purpose of these elastic fibers is to help the alveoli from collapsing on itself. There's other factors too, but the elastic fibers will help to keep the alveoli open so that air can flow in. Other things I want to point out are the capillary beds. Notice that this is where the exchange of gases takes place, and the red vessels here, they're going to carry away the oxygenated blood, and the blue vessels, these are the veins which are bringing the deoxygenated blood to the lungs. And there are also nerves shown here. We will see how the autonomic nervous system will control the rate of respiration later next week. Notice also there are a lot of these smooth muscles around the terminal bronchiole. The diameter of these bronchioles can be controlled by either the contraction or the relaxation of these smooth muscles. And when the smooth muscles contract, you see that the air won't flow freely through them. It will be redirected to other bronchioles for flowing into this to take the path of least resistance. So now let's take a look at the structure of the alveoli to see what are the various cells which are found here. I have an upper panel and a lower panel because I think some aspects of the alveoli are clearer in one panel versus the other. So I'll show you what those various parts are side by side. So we see that there are these type 1 pneumocytes shown here in purple, and these are the type 1 pneumocytes shown in light green. And if you look at the second figure, it's a lot clearer that these are actually simple squamous epithelial cells. Right? They are these flattened epithelial cells, and they will be the site of gas diffusion. you can appreciate how they are flattened in this lower panel rather than in the upper panel. And then there are these alveolar macrophages. They are not shown in the lower panel. These are just immune cells which will patrol the respiratory system and help phagocytose any sort of pathogens. And notice there are a lot of blood vessels which will be found surrounding the alveoli, and these blood vessels are made up of the endothelial cells. These are also simple squamous cells. And in the blood vessels, you notice that there are these erythrocytes which will help with the transport of oxygen. And surrounding the alveoli in the periphery, you notice there are these elastic fibers shown here, and the lower panel that is denoted by these purple spring-like structure, that is the elastin fibers, and the dark purple band is indicating the basal lamina, which will support the type 1 pneumocytes. Now the second major type of cells I want to draw your attention to are these type 2 pneumocytes. It's shown here in yellow on the upper panel, and the lower panel is shown here in dark green. The purpose of these is to release surfactants. And surfactant will be this amphipathic substance shown here, because it's got a hydrophobic and a hydrophilic region, and the surfactant will help to decrease the surface tension. So you may be wondering, okay, where is the water in order to decrease the surface tension? And there is this very thin layer of water lining the type 1 pneumocytes, and that water will enforce the surface tension, which will cause this alveoli to collapse. And so the surfactant will reduce the surface tension and keep the alveoli open. And when you have a lack of this surfactant, it can lead to a condition known as the respiratory distress syndrome, where the alveoli will collapse after each exhalation. And the reason you don't have enough surfactant could be due to genetic or abnormalities, or even due to injury. But I want to draw your attention to one population which can suffer from this respiratory distress syndrome, and those are the premature infants. And the time when surfactants are being produced, the fetus is during 25 weeks, and when infants are born before 37 weeks, that's one of the reasons why they have to be put in the NICU, the neonatal intensive care unit. And if they don't have sufficient surfactants, they can get artificial surfactant therapy. Now, in general, most babies should survive even if they are born after 34 weeks, because they have sufficient surfactants produced. But if they don't have it, then they can administer artificial surfactants and other kinds of needed therapy for the survival of the infants. So that being said, we can now move on to seeing how gas exchange can happen across the blood-air barrier. Now in this figure here, you notice you have the alveolar airspace. This is the space into which the air will flow in. And it has to move past, there's one layer here, another layer here, so it has to get past 3 layers before it can enter the capillary lumen and eventually move into the red blood cells for oxygen to move in. Now the first two layers are made up of cells. The first layer is the alveolar cell layer, shown here in purple. And I told you this layer will have, this layer of cells will have a lining of water on it, and so the surfactant coating that water surface is shown here. Now the second type of cell layer is the capillary endothelium, shown here in red. And both the capillary endothelium and the alveolar cell layer both are going to be held together by a basement membrane in the middle, shown here in blue. Now, for air to move across these 3 layers, it's not much of a problem, because firstly, the distance is quite short. It's only 0.5 micrometers in width, and the air is pretty lipid soluble, so oxygen and carbon dioxide can easily diffuse past this lipid bilayer of these cells and also past the connective tissue. So keep in mind that the first two layers, they're made up of, they're referring to the cells, and the third layer in the middle is made up of connective tissue. So having described how air can diffuse past the alveoli into the capillary lumen, let's look at the two lungs. So when you look at the two lungs, there are a few differences, right? And the major difference, what's your question?
So the basement membrane is not made of cells?
It is connective tissue. Yeah, so the question is, the basement membrane, what is it made up of? It's made up of connective tissue, which is supporting both those layers of cells. Okay, so now when you consider the two lungs, there are a few differences, and the major difference is that the left and the right lung, they have different number of lobes. So the right lung has got 3 lobes, the left lung has got 2 lobes. And these lobes are separated by fissures. Right? And the right lung has a horizontal fissure which separates the superior and the middle lobe, and the oblique fissure will separate the inferior lobe from the superior and the middle lobe. In the left lung, there's only one fissure, which is the oblique fissure, and it will separate the superior from the inferior lobe. Another difference you see is that the left lung tends to be longer, and the right lung, on the other hand, is more wider and shorter. And the reason for this is the organs which are surrounding the lungs, which cause these type of changes in shape. So for the left lung, there's this cardiac notch. That's where the apex of the heart will be pushing in. So that's this cardiac notch to accommodate the heart. And the reason why the right lung is shorter is because it is trying to accommodate the lobe of the liver. So the liver is going to push up on the right side. That's why the right lung is not long, it's shorter. And I mentioned the various types of lobes because there is this surgical procedure known as pulmonary lobectomy. And this is a procedure where a specific lobe of the lung could be surgically removed because that lung may have cancer or may have some type of infection. And removing this lobe will prevent the cancer or the infection from spreading to the other lobes, and the remaining lobes will be able to function quite independently. So in order to highlight this surgical procedure, I had to talk to you about the different types of the lobes found in the various lungs. So when you take a look at the surface of the lung, we find that there are actually 2 layers. Right? There is this visceral pleura, which is directly in contact with the lung, and then there is this parietal pleura, which is found outside the visceral pleura. This parietal pleura will be in contact with the thoracic cavity. And both these layers, they have a space in between them which is known as the pleural cavity. And because there are pleural cavities in both lungs, we'll see what is the function of these pleural cavities in the upcoming slides. Just a few more things about the parietal pleura. Notice that it's going to cover the inner surface of the thoracic wall. It's also going to extend over the diaphragm. So the diaphragm will be found inferior to the lungs, and it is this parietal pleura which is in contact with the diaphragm and the thoracic wall. Now the visceral pleura, it's going to be directly in contact with the lungs, and it's going to extend into the fissures which were separating the various lobes. So the visceral pleura is really in intimate contact with the lungs. Do you remember where else we talked about 2 layers surrounding an organ previously? Yes, the heart. Thank you. You can say it out loud too.
I did. I just said it very quietly.
Oh, okay. So when you add the cardiovascular system is on exam 3, folks. So yeah. If you go back to the analogy of putting your hand in a balloon which is not fully inflated, you notice that the part of the balloon which is in contact with your fist would be analogous to the visceral pleura, whereas the part of the balloon which is not in contact with your fist, that would be the parietal pleura. And the question is, why do we care about these pleural layers, and also what is in the pleural layers? Well, there are two very important reasons, right? The first reason is that within this pleural cavity, you have a pleural fluid, and this pleural fluid is going to help minimize the friction as the lungs will expand and contract. And whenever you have these organs which are going to change their shape regularly or rhythmically, it's important to minimize the friction between the inner layer and the outer layer. So there's this pleural fluid. That's the first function, right? The second function, I'll get to it in a couple of slides, right? And notice that this pleural cavity is said to be a potential space because the space between the two pleura is pretty close, and it is filled with fluid. It's not empty. So now that we've talked about the various components of the respiratory system, starting with the nasal cavity, down to the alveoli and the lungs, we can actually see how all of this works together, right, to help with respiration. So when you think about respiration, I told you there are two parts. You have internal and external respiration. And external respiration is what is shown here. Okay? We see that it is including all the processes, right, which are involved in the exchange of oxygen and carbon dioxide between the interstitial fluid and the external environment. So the external environment is referring to the space within the alveoli. That's where the air comes in. So the exchange from that alveolar space into the interstitial fluid is external environment. And interstitial fluid is referring to the fluid which surrounds the cells, and from there it can eventually enter into the bloodstream. Now the internal respiration, on the other hand, will be the absorption of oxygen by the cells and also the release of carbon dioxide by those very same cells. And what happens in internal respiration is going to refer to all of the biochemical pathways where oxygen is utilized and carbon dioxide is produced. So we haven't talked about every single pathway in the body, but can you tell me of a major pathway where oxygen is going to be used? Starts with E. Electron transportation. I like giving clues like this. What about where is carbon dioxide produced? At least one cycle. Krebs cycle, TCA cycle, citric acid cycle, all of those work. Okay? So our focus will mainly be on external respiration because we've already discussed what happens in terms of internal respiration in the previous units. So in external respiration, the first step is going to be what is known as pulmonary ventilation. Right? So when you say a room is well ventilated, it means a lot of air is coming in the room and going out of the room. Right? So pulmonary ventilation or breathing is physically moving air in and out of the lungs. So that is the very first step, and we will spend most of today's lecture talking about what are the factors underlying pulmonary ventilation. And then once you have air moving into the lungs, there will be gas diffusion which needs to take place in the lungs, right, between the alveolar air spaces and the alveolar capillaries. So that's the first place where gas diffusion takes place. And then gas diffusion will also take place in the tissues between the capillary walls and between the blood and the other tissues. So that's the second place where there will be diffusion of gases. And keep in mind there will also be transport of oxygen and carbon dioxide. This transfer of oxygen will take place in the lungs, right, between the alveolar capillaries, and also take place in the tissues between the capillary beds as well. And when we come back next week, we'll see how the transport of oxygen and carbon dioxide will take place through different mechanisms, right? And that's something we'll consider in greater detail. And internal respiration, as I mentioned, it's something we won't go into any more details. We've already considered it sufficiently in the previous units. So let's start with step one of pulmonary ventilation. What causes pulmonary ventilation? So we see that air will flow from an area of higher pressure down to a region of lower pressure. And to better explain this, I need to start by talking about how molecules in a gas will interact with each other versus molecules in a liquid versus solid. You remember when I showed you this picture first? When was it? Lecture number 2 actually, not lecture 1. So it's number 2. It's okay. But the bottom line is, the reason why I wanted to highlight which lecture I showed you in is, if you haven't been working on RPAs one as yet, please go back and work on it. Right? These are concepts you can't run away from, and I really hope I'm encouraging you to practice at least one unique RPA per day. Okay, and go back once you finish them. So when you look at this picture, we see that water vapor is shown, right? Water in its vapor form, there's water in the solid form as ice, and also water in the liquid form. Now when you look at the water in the gas form, we see that each molecule of water will be acting as an independent object and will bounce around. Whereas in the liquid state, you see that the water molecules are quite close in contact with one another. So if you were to take this gas and you put it in a container, depending on the volume of the container in which you put this gas, there's going to be pressure exerted. So notice that the pressure will be exerted by a gas because these gas molecules, they act like independent objects, bounce against one another, and also will bounce against the walls of the container. Alright, so let me highlight this last statement by showing you these 3 panels here. So in each of these panels, if you don't believe me and you choose to challenge what I just said, if you count and see, there will be 14 black circles. Right? So each of these black circles, they're indicating a molecule of a given gas. And when you put these 14 molecules in a larger box, right, we notice the number of collisions by this single gas molecule is going to be 4, right? 4 collisions. You decrease the box size somewhere, there will be 5 collisions. You decrease it even further, there will be more collisions, 6 collisions. Right? So we see that as you change the volume, right, the pressure exerted by gas will change. And so this ties into Boyle's law, which explains how pressure is inversely related to the volume of the container. And so we find that when you decrease the volume of a given container, the frequency of collisions will go up, and as a result, the exerted pressure will also increase. In contrast, if you were to increase the volume of a given container, and you're going to decrease the frequency of collisions, and thereby you will decrease the overall pressure exerted by the gas. Right? So here's a fun analogy to think about. I think this is a pretty simple concept, right? How pressure and volume are inversely related. But look at these 3 balls bouncing around in a box, right? And notice this box is gradually increasing in size and then getting smaller again. So do you think the speed of the balls are changing as the box size changes? You think yes or no? You can make your voice be heard through the projector. Okay. Most of you said no, and that is correct, right? So we find that the speed of the balls is not changing. It's just that there are more collisions in the smaller box, and so it looks like the balls are moving faster, right? But actually their speed doesn't actually change. So now that I've repeated this concept that changing the volume is going to have an impact on pressure, the question is, how does the lung volume change, right? And so we come back to the pleural fluid, right? And I told you that the pleural fluid and the pleural cavity has 2 functions. First function was to decrease the friction as the lungs expand and they relax. Second one is that there's actually a fluid bond which will exist between the parietal pleura and the visceral pleura covering the lungs. And this fluid bond, it's similar to when you have two wet pieces of glass, right, stuck to one another, and you try to pull it apart. It won't come apart easily because the air pressure acting on those two glass slides will be greater than the pressure within those within the two glasses and the water film. So it's going to keep those two glasses stuck to one another. Similarly, we see that because of this fluid bond, it will cause the surface of each lung to stick to the inner wall of the chest cavity. So it's going to stick to this inner wall of the chest cavity and to the superior surface of the diaphragm. So we find that the lungs are sort of like stuck together because of this fluid bond to this diaphragm and also to the thoracic cavity. And so whenever there will be changes in the shape of the diaphragm or in this thoracic cavity, the volume of the lung will also change accordingly. Are we clear on this? The movements of diaphragm or the rib cage will change the volume of the thoracic cavity and also the volume of the lungs, right? Because they are held together by this fluid bond. So now let's talk about what are the various factors which can change this lung volume, right? And we will first focus on what will increase the lung volume because that's what needs to happen to ensure inspiration or to bring oxygen-rich air into the lungs. So the first one will be muscle contraction, right? And we'll consider two types of muscles here and how both of their contractions will increase the lung volume. First one is the lowering of the floor of the thoracic cavity because of the diaphragm. So the diaphragm is relaxed and it's a dome shape, but as it contracts, it's going to flatten out and increase the thoracic cavity volume. Secondly is contractions which cause the rib cage to expand, and this is referring to the intercostal muscles which are found in between the ribs. The second factor is going to be a negative interpleural pressure which is existing because of the interpleural fluid. You see that this will help to suction the lungs to the thoracic wall as I showed you in the previous slide. And we'll see how, if you were to affect this interpleural pressure, how it can have a negative impact on air flowing into the lungs. Thirdly, there's the elastic recoil of the thoracic cavity. And this is mainly because of the way in which the ribs are held together and also the muscles and the connective tissue which is holding on together. There will be this thoracic wall having a recoil. Right? We won't be getting into any more details of this one point, but we also find that the amount of surfactant in the alveoli will also prevent the alveoli from collapsing, even though it has this layer of water which increases the surface tension and causes, once the water collapses, but the surfactant will prevent that from happening. So we will talk about the muscle contraction, negative interpleural pressure, and the surfactants in the upcoming slides. So let's talk about the diaphragm contraction. Right? Notice that the diaphragm, when it's relaxed, it's going to be dome-shaped, right? And it's going to project superiorly into the thoracic cavity. But then as it's contracting, we see that it's going to move downward, move inferiorly. That causes the volume of the thoracic cavity to increase, and the pressure inside the thoracic cavity will decrease. All because of Boyle's law, where you have an inverse relationship between pressure and volume. And when the diaphragm relaxes again, it again goes back to this dome shape, and that will decrease the volume of the lungs and increase the pressure, causing air to be expired. So here's an animation showing you that as the diaphragm relaxes, notice it's getting dome shaped. As it contracts, it's getting flattened, and as it relaxes, the thoracic volume decreases. As it contracts, the volume increases. Right? So now let's talk about the second type of contraction which changes the lung volume. So we find that there are articulations. Now the articulation means this is the joints. Right? There are articulations between the sternum, shown here, and also between the ribs and the vertebrae. Right? And because of these articulations, when you have the contraction of these intercostal muscles, it will make the rib cage to rise up, right? And so you can do this with your own hands. Imagine your fingers are the ribs, and you bring it close together, and as you bring them up closer, right? Imagine the intercostal muscles contract, it flares out like this. Right? Yep, that's right. And as they flare out, the volume increases, and that causes a drop in pressure, and thereby air will flow. So the contraction of these intercostal muscles will increase the thoracic volume, decreasing the alveolar pressure. Whereas as the intercostal muscles relax, the thoracic volume decreases, the rib cage is lowered, and that can cause air to flow out. So if the hand analogy, the hand props didn't work, never fear. Here's a nice animation to show you what it looks like. Right? So during inspiration, rib cage rises up. During expiration, it goes down. And what causes the rising up of the rib cage is the contraction of the intercostal muscles. Are we clear, folks? All right. You don't seem very satisfied, so I wasn't sure. Okay, now moving on, let's see how the pressure volume will change during respiration. So in this figure, all I'm showing you is that air will flow from a region of high pressure down to a low pressure. Right? And in this specific slide, I want to point out there are 3 different pressures we will have to consider. Right? The first pressure is the pressure in the atmosphere, abbreviated as P subscript ATM. And then you have the pressure in the alveoli, which is abbreviated as P subscript A. And this is the pressure in the lungs. You can use either term interchangeably. You can even call it the interpulmonary pressure as well. And thirdly, we have the interpleural pressure, abbreviated as P subscript IP. Now, you'll notice that the pressure in the lungs, right, or the alveolar pressure is 760 millimeters of mercury, and that will be the pressure inside when you're not breathing air in or out. And the atmospheric pressure will also be 760 millimeters of mercury. How we came up to this number, I will explain later in today's lecture. And the interpleural space, there the pressure is slightly lower, it's 756 millimeters of mercury, right? And it has to have a lower pressure. And I'll tell you how these various pressures will change when you breathe air in and out. So when you're breathing in, this interpleural pressure will be lower than the atmospheric pressure, will be lower than the pressure in the alveoli and the pressure in the atmosphere. When you're breathing out, notice that the alveolar pressure will be higher than the pressure in the atmosphere. And in both cases, the interpleural pressure is always lower than the interpulmonary or the pressure inside the alveoli. So let's see how these pressures will change in a given cycle of breathing in and breathing out air. So here's the right pleural cavity shown here. Here's the left pleural cavity shown in blue, and the diaphragm is denoted here in brown. And the interpleural pressure, I'm going to highlight it using the blue color. And in red, we'll see the interpulmonary or the pressure in the alveoli or in the lungs. So there are 3 panels shown here, right? In the first panel, shown in red, is the changes in the interpulmonary pressure during a single respiratory cycle. So in the single respiratory cycle, you have inhalation and you have exhalation. And then in the lower panel, we see changes in the interpleural pressure during a single respiratory cycle. And in the third panel, we find this is the plot showing the amount of air moving into the lungs and out of the lungs during a single respiratory cycle. Right, so let's walk through each of these panels. So we see that in all these 3 panels, we'll see how pressure and volume will change in respect to time shown here. So in the first panel, we see that the pressure is shown as 0 because this is the difference between the atmospheric pressure and the pressure inside your lungs. Right? So when you're at rest, not breathing anything, you have same pressure between the atmosphere and the pressure in your lungs. But then as you start inhaling in, we see that the pressure is gradually dropping, right? And it can go as low as -1. So this is going to 759 millimeters of mercury. Right? And as this pressure is going down, notice that the volume of air will start increasing because air is flowing in. Right? And as air is flowing in, notice that this pressure gradually starts increasing again because the amount of volume available for air to flow in is decreasing because air is flowing in, and that's why it eventually goes back up to 0. There's no longer a difference, and we see that you've reached the maximum peak volume which will enter into the lungs. And then when you start exhaling, you see that the intrapulmonary pressure is gradually going to get higher than the atmospheric pressure, and that's when air will be forced out of the lungs. Now, in this entire cycle, right, if you look at the interpulmonary pressure versus the interpleural pressure is always lower, right? It's 4 millimeters of mercury lower. And if it doesn't stay lower, there will be problems, right? And let's look at an example of what will happen if this interpulmonary pressure is affected. So a condition which can cause the interpulmonary pressure to be affected could be an injury to either the visceral pleura or the parietal pleura. So here is a knife wound to the parietal pleura, and when this wound happens, the interpleural pressure will start to equalize with the atmospheric pressure. And so air will flow from the atmosphere into this interpleural space, and thereby the volume in this interpleural space will start increasing very rapidly and cause this lung to collapse as shown in this animation. Right? So air flows in and the lung will collapse, and this is called pneumothorax. So this animation is indicating how the lung volume is changing as the interpleural volume increases. But what is happening to the changes in pressure? Right? So if you look at this animation here, when the lung is fully inflated, it's got the interpleural pressure is -4, but as the lung is collapsing, the interpleural pressure is equalizing with the atmospheric pressure. And I hope this analogy explains why it's very important to have a negative interpleural pressure. So what would happen if the parietal pleura isn't affected, but rather it's the visceral pleura, right? Then the air from the lungs will start moving into this interpleural space, and in such a case you would have to remove this air in the interpleural space, and then the lung can be restored back. Okay, now we'll move on from seeing what are the factors influencing inspiration to see that even, we will continue to see what can influence inspiration, and that one is compliance. And so compliance is just referring to a measure of how easy it is to inflate the lungs, and this is going to depend on two things. Firstly, we see that there should be negative interpleural pressure, as we just now considered, and secondly, there's also the presence of the surfactant, which will decrease the surface tension of the water layer in the alveoli. And so this alveoli is going to experience some pressure to collapse, right? And that pressure to collapse can be explained by the law of Laplace, right? And so we find that this pressure to collapse, P, is equal to 2 times the surface tension due to the water layer divided by the surface, divided by the radius of the alveoli. So if you had 2 alveoli of different radius, right, you would be experiencing different types of pressure to collapse. So which of these 2 alveoli, the bigger one or the smaller one, would require more surfactant to prevent it from collapsing? Do you think the small alveoli will require more surfactant or the bigger one? You guys can tell me through the poll everywhere. Okay, we've got a few responses. Ooh, wow. Mostly we said larger one needs more. Okay, that's not correct. The smaller one will need more surfactant. Let me explain what. So notice that the radius is inversely proportional to the pressure, right? So the smaller the radius of an alveoli, it's going to have a greater pressure to collapse, right? And so to offset this greater pressure, you would need to reduce the surface tension by having more surfactant. But if you have a larger radius, the pressure to collapse is smaller, and so you need less surfactant. And this picture here is sort of indicative of that. Notice that each of these blue circles is indicative of surfactant. You need less surfactant in the larger alveoli of a larger radius versus the alveoli with the small radius. Are we clear? Fantastic. All right. So now let's talk about how expiration will take place. Right? So we find that the elastic recoil of the alveolar walls will lead to expiration, and the factors which influence this elastic recoil would be the surface tension of the water in the alveoli, and also the elastin in the extracellular matrix. You remember those purple colored springs which were shown at that cartoon. So both of those can cause the elastic recoil of the alveoli. There can also be some muscle contractions which can help with expiration, and you may be wondering, did you just say that contraction of the diaphragm and the intercostal muscles causes inspiration? That is true, right? So we look at the contraction of other muscles which will help with expiration, and this plays a role only when you're having forced expiration. And notice that the abdomen the contents will be forced out against the thoracic cavity, and that can help with forced expiration when you're exercising intensely. So before we end, I want to come back to the number I told you, 760 millimeters of mercury is the air pressure at sea level. How do they come up with that value? So the way we measure air pressures nowadays digitally, but let me tell you how this mercury barometer works. So there is a bowl with mercury in it, and then there's a tube which is sealed at one end but open at the other end. Right? So you use this open end to fill it with mercury fully, and then you invert it into this bowl of mercury, and then you open the open end. Now if there was zero air pressure, all of this mercury should just flow into the bowl. But the fact that only little amount of mercury has flown into the bowl means that there's this air pressure on the exposed surface which is preventing it from flowing into the bowl. Now the air pressure we experience on planet Earth really depends on where you are on planet Earth. Right? So if you are at sea level, we will have higher air pressure because the air density will be higher at sea level. But if you were to go all the way up to the mountain to Mount Everest, you will have lesser air density and the air pressure will be less. So let me give you some few values. At sea level, you will have air pressure of around 760 millimeters of mercury. Here at Fort Collins, it would be 630 because we are at a higher elevation. And if you went all the way up to Mount Everest, it would be 252 millimeters of mercury. Right? But even though the air density changes, the composition of air does not change. Right? Regardless of where you are, the percentage of oxygen in the air will be 21%. Right? And nitrogen is 79%, water vapor 0.5, and carbon dioxide less than 0.05. So we will stop there, and I will come back to Dalton's law on Monday. Right? Enjoy the weekend. Don't forget working on the RPAs and also work on your key questions. I will see you on Monday.